apart from abscesses of around the appendix, showed another pathology that was described as a mass of unclear origin that was located laterally to those abscesses. The patient was qualified for a laparotomy that showed the phlegmonous appendix with its distal end enlarged with tumor masses and adjacent to the mesentery, as well as another tumor mass of the mesentery. Appendectomy and the resection of the tumor masses were performed, and the subsequent pathomorphology exam showed the tumor masses to be G1 neuroendocrine neoplasm of gastrointestinal tract, also called carcinoid. The patient was asymptomatic, and the laboratory studies were negative for carcinoid syndrome. On the basis of the tumor classification as T2, N1, and N0, the patient was qualified for a right hemicolectomy procedure with the resection of regional lymph nodes, as well as the one suspicious retroperitoneal lymph node. The subsequent pathomorphology exam showed the presence of 4 metastatic lymph nodes out of 17 altogether detected, but there were no signs of neoplastic cells in the retroperitoneal lymph nodes. Then the patient remained under oncologic observation, but sometime after, by another imaging studies of conjoined PET CT, as well as CT and MRI, show the presence of tumor mass in rectal vesical pouch. And the patient neurotomy, and the tumor was excised, and the pathomorphology exam showed it again to be a well-differentiated neuroendocrine tumor. And up till now, patient remains under oncologic observation, and no new pathology has been found. To conclude this case, in this patient, the appendicitis revealed the presence of a neuroendocrine neoplasm, and it's good to remember about this pathology as a differential diagnosis for acute appendicitis, and to be able to apply accurate diagnostic and treatment protocol according to the newest recommendations. Thank you very much.
How frequent are such tumors?
Generally, I don't have the exact data, but it is generally said that they are typical amongst adults. So this is quite rare for this neuroendocrine tumors to occur in children. But unfortunately, I don't have the.
Is there any specific age it's more common in a group of children? No.
No, I didn't find any data on it.
Thank you.
I see that, X-rays becoming more and more popular for case or student case reports. That's great. My question would be, because as a general comment, not only to your presentation, but to all presentations, those are partially your patients as you describe them, but you're not the primary physician for those patients. So the most important thing to me presenting is a good literature search and a good sound knowledge of what you're presenting. So my question would be, for example, if I ask you, what is this? You would say this or this.
These are the bones of the pelvis. Excuse me?
Which bones? What bone would that be? Or let's say this one, it's easier to recognize, because that would be, this image would be higher, more superiorly than this one.
Sorry, I just, it's the problem that right now I can't, remember
no problem, no problem. So,
English for this will be.
This one, those?
I think this will be muscles.
Sure. Here.
Do the muscles or the kidneys?
Kidneys.
Yes, these are
That's definitely better. Okay, thank you.
Okay, also some general remarks. Please do not put so many text in the poster. It's not a book page, okay?
Right.
And the second thing, if you are putting down the references in the bottom of your poster, always use a good present medical literature. Do not try to avoid using 10, 12 years papers. Always use current medical papers. Okay, those are two of my remarks. And I have a question. Can Alvarado scale for appendicitis can be implemented in pediatric surgery or not?
Sorry, could you?
Alvarado scale, you know what this is?
The Alvarado. I remember about the Alvarado scale, but there are my colleagues from.
Yeah, because you can, based on Alvarado scale, you can qualify a patient to a surgical procedure, conservative treatment. My question was, do you use it in pediatric patients? So can you use Alvarado scale in pediatric patients?
Yes, they don't recommend it completely, but
Okay.
you can use it.
I know location of this type of tumor is about 5% in the appendix, as far as I know. Okay, so thank you very much. Yes.
Yes.
So I don't think it was personally present. So it was a kind of progression.
I think that the symptoms were just because the tumor mass must have obliterated the lumen, and the subsequent symptoms of appendicitis occurred in this patient. That's what I think. Yes, exactly. That's what I would call it. The most common. Yes. Thank you.
Thank you very much. Thank you. And now Agnieszka Stańko will present her poster.
Dear ladies and can you hear me? Dear ladies and gentlemen, my name is Agnieszka of Medical University of Gdańsk, and it's a great pleasure for me to present you this case report, which I think is very pedagogical. The topic is sudden cardiac arrest due to epileptic seizures in 5-year-old boy. The diagnosis, I would like to start from the case report. An unconscious 5-year-old boy was brought to the intensive care unit after the sudden cardiac arrest. In the figure 1, we can see the ECG fragment at the moment of admission. Here we have the ventricle tachycardia and spontaneous return of the sinus rhythm. This kind of imagine was seen several times during hospitalization. Information obtained from parents, the boy with a negative family history had been on the neurological care because of epilepsy for 2 years. The ECG examination was negative. This time, it was the third seizure attack since the pharmacotherapy had been started, and was similar to the previous ones. Appeared at sleep and resulted
in fecal and urinary incontinence. This time, the attack was longer, and when the shortness of breath appeared, parents started animation, subsequently continued by the breastfeeding. Ventricular fibrillation was diagnosed, and after the fibrillation and amiodarone admission, the sinus rhythm returned. During the hospitalization, there was ECG precise that long QT syndrome was diagnosed, and the pharmacotherapy was started. As the status of the patient became stable, the left cardiac left cardiac denervation was and implantation of the cardiac cardiovascular were performed. Since that moment, seizures haven't appeared. The ECG was done to the family of the boy, and one of his sister was also diagnosed with long QT syndrome. Recurrent seizures are usually diagnosed as epilepsy, despite the unsuccessful treatment. Long QT syndrome is inherited cardiac disease characterized by prolonged repolarization of ventricle and the high risk of sudden cardiac death, and usually manifested as seizures. There are many cases of diagnosis described in numerous publications about the loss of diagnosis and what prolongs the status when the patients have a really high risk of the sudden cardiac death. So, as a conclusion, I just want to say to remember about the importance of differential diagnosis and about the value of the ECG. Thank you.
Thank you for a very nice presentation. Don't worry. I mean, it could happen to anybody that you lose a word.
I just lost the word, you know.
Just went blank. No worries. My question is, what is the most common mechanism in children for cardiac arrest?
The most common, this is the most common, actually.
Long QT? Nope. Two general mechanisms in which a cardiac arrest might occur.
Oh, I don't know.
It's helping you.
I don't understand.
So it's either respiratory or circulatory. The most common is respiratory. So did in this case, did it occur to you that it could actually be asphyxia during an epilepsy attack that led to the cardiac arrest?
No, because actually the typical history of this child and this typical image at the ECG, which is like characteristic for long QT syndrome, I think that it was the common mechanism.
Because in this, so but to get the facts right, I mean, first was the epilepsy attack, then cardiac arrest.
Actually, it was epilepsy, but as I said, that EEG examination was negative, and you know, if there is because the typical manifestation of long QT syndrome are recurrent seizures or recurrent syncope. So and these symptoms are unspecific. To think about the long QT because it's a rare condition, but that thing that it appeared a lot of times. And this, imagine, is typical. It's difficult to make the genetic diagnosis in Poland because actually the patient has to pay for it. And it costs about 2,000 euros per patient. And we have the whole family to diagnose. And, you know, if the treatment is successful, so it's the most important thing to decrease the risk of the cardiac death.
Thank you very much.
Thank you.
You don't go anywhere. So I have a question. You said that the pharmacotherapy to the cardiac arrest, right? Pharmacotherapy by anti-epileptic drugs was prior to the cardiac arrest. So what type of drugs did you use?
Depakine.
Depakine, so valproic acid, right?
Yes.
One of the leading pharmacological causes of prolonged QT is valproic acid.
Yes, maybe, but you know that the symptoms was the first one, because firstly the patient had seizures and then he had the cardiac arrest because before the treatment of the epilepsy.
I asked you if the therapy for epilepsy was administered prior to the cardiac arrest, right?
Before.
Yes.
Yes, it was.
Yeah, so the prolonged QT might be caused by the treatment of epilepsy.
Yes, I can.
Carbamazepine and valproic acid causes prolonged QT.
Yes, of course, but the symptoms appeared before the therapy, not after. So we can say that the epilepsy caused the attacks. And now the attacks, the patient doesn't don't need to, doesn't take anti-epileptic drugs, doesn't take, and the therapy helped him. So it's, you know, it's.
I'm asking you only if the patient,
Yes.
prior to the cardiac arrest, was he taking valproic acid, Depakine?
Yes, I told it.
Okay. So prior to the cardiac arrest, right?
Yes.
So if the patient even had underlying QT syndrome, the administration of the inaccurate anti-epileptic drug could aggravate it and cause the cardiac arrest.
Yes, of course. It's good.
So I would see there, because in patients that have pre-existing QT, we use regularly, we don't abuse all anti-epileptic drugs such as carbamazepine, oxcarbazepine, and valproic acid. We would like to use, for example, Tegretol. So, thank you very much.
Thank you. Yes. 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 We can say that they don't have appearance of long QT syndrome in the ECG because 25% of patients with more 10 times more risk of the sudden cardiac death than population, but we couldn't did the genetic diagnostic, so we just know that the sister presents long QT in ECG, and she was asymptomatic.
Thank you very much.
Thank you.
And now Agnieszka Skórzak will present.
My name is Agnieszka Skórzak. I'm from Medical University of Lublin. I want to present a case about 19 years old female patient after a failed suicide attempt. As we know, suicide is now the second least cause of death for teenagers and young adults in Poland. So it's a problem and it rises. Also, it often leads to severe pelvic fracture, which is a serious problem in a trauma surgery. Severe pelvic fracture are one of the most common caused by suicide attempts. And the girl was admitted to the hospital after she leaped from a fourth floor window in a suicide attempt. She organ injury, which included unstable pelvic fracture, comminuted fracture of the left calcaneus, and comminuted fracture of the right calcaneus. After the patient's vital signs were stabilized, the surgical on the lower extremities were performed. When the patient was transferred to the clinic of orthopedics of the Medical University in Lublin, as shown by radiography in the clinic, the posterior surgical approach for stabilization, sacral fracture, and lower iliac stabilization were performed, and the anterior intrapelvic approach, the stabilization of anterior acetabulum outcome is dependent on proper management of damages. In this case, the full therapeutic success is possible only with coexistence of the patient's good physical as well as mental state. Thank you.
What was it bleeding from? It was just like patient was coming with pleural hemorrhage. What was this bleeding from?
It's a pleural hemorrhage. It was pleural hemorrhage.
For this very nice presentation. Is this a student psychiatric group writing about orthopedics or a student orthopedic group writing about psychiatry?
Students orthopedic group.
Okay, okay. So this changes the scope of the questions. My first question would be, is this the most common way you fix the calcaneal fractures? I mean, with Kirschner wires?
But these fractures are not over surgery in our clinic, but in our clinic, only a pelvic fracture was made.
Okay, but can I dwell on the subject? How would you fix the calcaneus? Yes, because students orthopedic group, I mean, you will do it at some point.
Yes, I think this way.
Okay. And how long is the follow-up after the treatment currently for this patient?
About 1 year.
1 year. And what are
now, for example, pregnancy is possible in this case, but it's a good.
but coming back to more basic matters, how is she walking? Is she ambulating without crutches?
Now she's walking.
Crutches or without crutches?
With crutches.
Crutches.
And her state improved one day to day.
Okay, and what is the state of bone healing? Are you considering implant removal at some stage or from the pelvis? I mean, are you thinking of the plates from the iliac crest? Doesn't matter.
Okay.
Thank you.
Thank you.
Thank you. Very good case presentation. What was the indication for the lumbar iliac stabilization? Do you usually, when it comes to fractures, do you usually stabilize upwards to the lumbar spine?
Yes.
And without any pathologies in the lumbar spine, right?
Yes.
Because probably if you had a concomitant fracture of the lower lumbar spines, you would probably stabilize upwards or downwards.
I don't know, for example, upward.
So you have this type of patient, but you have a burst fracture of the L4 lumbar vertebra. What do you do?
all day.
Yeah. Like a very smart girl, what would you do?
It was stabilization and operation like this.
Okay. So you would operate like this. How many more screws or less screws would you put in the vertebra? So, for example, just tell what we would do. If you have an iliac fracture here and a fracture of the L4, which is about here, you need to stabilize and put 4 more screws in the L3 and L1, L2. So if you have a fracture in unstabilized fracture, for example, burst fracture, you have to stabilize 2 segments upwards and 2 segments downwards. Okay? For example, fracture of the L1, you have to stabilize TH12, TH11, and L2, L3. Okay? Thank you very much.
Thank you.
And I'd like to invite next participant, Helena Zbigniewska.
Honorable jury, ladies and gentlemen, my name is Helena Zbigniewska and I would like to present you a case report about a patient with radiating shoulder pain in the course of neuroborreliosis. Lyme disease is an infection disease caused by bacteria of the Borrelia type, and the most frequent sign of this infection is erythema migrans, but it doesn't have to be present in all patients. Borrelia burgdorferi enters the body through a tick bite on the skin, and it may later disseminate to the secondary organs. It can also cross the blood-brain barrier fluid, causing an inflammatory response or the neuroborreliosis. Infection can lead to neural dysfunctions such as motoric disturbances, nerve palsy, or persistent pain. A 30-year-old at London University College, complaining of the right shoulder pain radiating to the arm and hand, and left shoulder pain radiating to the arm. The left shoulder pain occurred later, so it was less severe. The pain was described in numerical rating scale as 4 in rest and at 8 to 9 in the moment of the highest intensity. Patient reported that the character of pain was constant with frequent exacerbations. She described this as an electrical shock-like feeling. She told that the pain is significantly disturbing her sleep, waking her at night, and it is affecting. And patient had a full range of motion in each shoulder joint. However, she experienced the muscle weakness and sensory disturbances. In MRI, no neck and head pathology revealed. And here we can see the radiation of pain. And the patient was bitten by a tick in August 2014. She experienced like symptoms such as muscle pain and general malaise, but there was no erythema migrans, and she received no medication due to the possible borreliosis. In October 2014, she came to emergency department, and she complained of the severe shoulder pain and limb paralysis. From there, she was referred to the Department of Neurology, where the upper limb mononeuropathy was diagnosed. Serology was IgM positive, but IgG negative. And the patient was referred further to Department of Infectious Diseases with suspicion of neuroborreliosis. In November 2014, her puncture was performed and it revealed inflammation in the central nervous system, but there were no meningeal signs. Serology was IgM positive and this time IgG equivocal. The treatment administered was ceftriaxone intravenously, and after 6 days, all symptoms subsided. After 1 month, symptoms recurred and the same treatment was administered. This time it helped for paralysis, but severe pain persisted. In January 2014, patient was hospitalized 1 more time in infectious diseases department. Serology was the same way in Western blot. And in cerebrospinal fluid, antibodies for IgG antibodies were found, but and IgM also, so antibodies to Borrelia burgdorferi were finally detected.
Patient was patient was diagnosed with the neuropathy of the upper limb in the course of neuroborreliosis, and she was referred to the pain treatment clinic. The prescribed medication was tramadol hydroxyzine. Side effects occurred. So when she came for the next time, the medication was changed for the dihydrocodeine, paracetamol, and codeine. Right now, and patient was referred to efficiency was suspected, and it was suspected because, as I told you, the IgG antibodies were found in January 2015, and it was 5 months after the tick bite, so it's a very long period of time. Yes, and right now patient is feeling good, the pain decreased significantly, and the prescribed medication is well tolerated. So to conclude, contrary to a popular belief, borreliosis is a widespread disease, and the lack of erythema migrans does not indicate its absence. So all patients reporting a tick bite should be evaluated and monitored carefully, because this disease can have asymptomatic beginning, and it can also have a progressive course if not treated in an early stage. Thank you for your attention.
One remark, I think it's not contrary to the popular belief, though according to popular belief, it's quite widespread disease. And one thing, what kind of side effects occurred up to the first line of painkillers?
She experienced discomfort in all mucuses, and she had blurred vision and dizziness.
Okay, so okay, thank you.
Thanks for a very nice presentation. What long-term sequelae would expect this patient? I mean, what could happen after going through for a patient that went through Lyme disease?
In this case of patient with
if you could hypothesize.
I think that she can develop some other conditions which are popular in borreliosis, such as arthritis, or, for example, okay, it's not very popular, but for example, endocarditis.
Exactly, that was what I was asking for.
Okay, thank you for a very nice presentation. 2 questions, or maybe 1 question, 1 remark. What was the indication for baclofen in this patient? Because baclofen is the GBA beta agonist, and it is recommended when spastic paresis develops. So it's a drug for spasticity. Did your patient have spasticity or any other muscle rigidities?
Yes, she had increased tension in major pectoral muscles. And actually, in the pain treatment clinic, the differential diagnosis was between the shoulder pain in course of neuroborreliosis and the pectoral major muscle myalgia. So I think it might be the reason.
Very blurry, but I think there is an indication. And it was a very nice presentation, but the conclusions are too general. It's like it's a very important clinical issue, and yeah. So why do you do a paper on not?
Okay, so
important clinical issues. So everything was great, really, but conclusions are too general. Okay, so let's try to do conclusions that flow directly from your paper. Okay, thank you very much.
Thank you very much.
I'm sorry.
Pan is Artur Kośnik.
Good afternoon. My name is Artur Kośnik. I represent the Liver and Internal Medicine Unit of Medical University of Warsaw. And I would like to present the first our knowledge Polish case of tacrolimus-associated inflammatory loss of myelin, especially in the pons. The etiology of this disease is still unknown, but probably the of the chronic hypoosmolar state is a common attributable factor of development of the central polymyelinalysis. And of course, it's really rare but really detrimental complication after the liver transplantation is associated with a mortality percent. I would like to present the case report of a 46-year-old man with diagnosed cirrhosis caused because of the hepatitis C, chronic hepatitis C, and the history of hepatitis B. Immediately before the patient was classified in the child throughput score as C11 points and the male score as 23 points. What is worth mentioning, the serum sodium concentration before the transplantation was within normal limits. After the transplantation, the immunosuppression was induced by basiliximab in 2 doses and methylprednisolone, and after it was maintained with prednisone and tacrolimus from the 5th day after the transplantation. During the first day after the transplantation, the patient had abdominal bleeding, and he required rhabdotomy to do the abdominal packing for hemostasis. And he recovered slowly, and in the 9th day after the transplantation, he was transferred to our unit, to liver unit, in the good general condition. But some days after, like 5 days after this transfer, the patient was drowsy. He developed dysarthria, dysphagia. He couldn't follow the comments. And then the next day, the head computed tomography was performed, but it showed no abnormalities. Then this condition of the patient worsened, and on the 17th day after the transplantation, the urgent MRI of the head was performed, and it showed the hyperintense area in the bones, which were consistent with the central pontimyelinolysis. Then no one knows what is the cause of the central pontimyelinolysis, because during the whole perioperative course, the serum sodium was within normal limits. Then the team decided to give the hypothesis of the neurotoxicity of tacrolimus. And the same day, the immunosuppressive regimen was changed from tacrolimus to everolimus. 1 week of the therapy of everolimus, the patient experienced significant neurologic recovery. He was responsive, able to speak, able to walk. Also, there was no dysphagia. And 9th day after the transplantation, the next MRI was performed, but it still showed the abnormalities in the bones, although the patient's condition was good in general. And then on the 37th day after the transplantation, because of the good state of the patient, also because of the excellent everolimus therapy, he was discharged home. After the 4 months after this, the patient had no neurological symptoms. The MRI showed the regression of the lesions in the bones. To sum up, thanks to this case, we know that tacrolimus may participate the central pontimyelinolysis, and its cessation from the immunosuppressive regimen may have benefit in patients who have any neurological symptoms. And also, in the setting of central pontimyelinolysis, we recommend using the everolimus and mTOR inhibitors. Maybe this emotional, but it was really important case for us, because one day we don't see any chance for our patient, but some days later we see this beautiful recovery, and that's the biggest happiness in being a doctor. Thank you so much.
Thank you very much for a great case presentation. This is, in fact, very interesting thing, because really nobody knows what the cause of is. I read one paper that indicates increased density of sodium channels in the pontine region. But can you tell me what is the region of the brain that has most justified increased density of sodium and potassium receptors? Or maybe where is the thirst center in the brain? Where would you suspect that the myelinolysis is mostly justified?
I think that the pons is the first place when it started.
No, in hypothalamus. In hypothalamus. But there
also
are
in
certain hypotheses that connect the myelinolysis caused by sodium, because it's like lysis. The increased influx of the sodium in the cellular membrane causes the rupture. So it's basic as that, and histopathological models of central point myelinolysis confirm it, but nobody knows what is exactly in the bones. Okay, so very good case presentation. Thank you very much.
Can I add? It was only 10% of the central pontine myelinolysis. Only in 10% of the patients was observed the extra pontine myelinolysis. So it's the way it is like.
Yeah, it's also extra pontine myelinolysis in patients that had correction of the hyposmall state too rapidly. They had myelinolysis in thalamus, for example. Thank you very much.
Okay, thank you so much.
Thank you. Be presented by Kamila Bong.
So, good morning once again. Now I represent the Scientific Association of Clinical Pathomorphology, Medical University of Dublin, and I'd like to present the case of pulmonary epithelial neoepithelial tumor of unproven malignant potential, a case report. Firstly, I would like to say that submucosal glands may be like neoplasm. And neoepithelial tumor is uncommon neoplasm in this group. It's low-grade neoplasm, and it is composed of two types of cells, epithelial ones. It may also be localized in salivary glands, nasal cavity, breast, paranasal sinuses, trachea, and bronchus and the skin. It usually affects people in middle age, and it's with slight selection to female sex. And now let's go to the medical history. 56-year-old patient was admitted to the hospital for X-ray, and it showed two our left lobes, and she had a history of left breast cancer, and she underwent due to surgery, and trans material was taken into histopathological examination. Here we may see that CT and X-ray showed not very well circumstances masses localized in left lobe, and it infiltrates pleura. Histopathological examination showed neoepithelial carcinoma with two types biphasic pattern. The inner layer was composed of epithelial cells, immunoreactive for cytokeratins, and the outer layer of neoepithelial cells, immunoreactive for protein S100 and smooth muscle actin. There was genetic studies performed, but they didn't reveal any abnormalities. And on the basis of the microscopic appearance, immunohistochemical profile, and genetic results, the final diagnosis. And pulmonary neoplasm, showing a mixture of both types of cells, are extremely rare, and there are only 25 cases described in the 19 years. And only one was localized primarily in parenchyma. Thank you.
According to the literature and your experience, what are prognosis for such cases?
Prognosis is rather good because this neoplasm had a small capacity to reoccur and to metastasize.
So all cases survived, yeah?
One unfortunately died.
Due to this disease, yes?
Yes.
Thank you for a very nice presentation. I always like histopathological images in a presentation. I wanted to ask you first what each and every one of those represents, but I see that they're described. I want to ask you, how did you perform your literature search? Where did you search?
I was searching the literature in PubMed, in PubMed, yes.
PubMed only using what keywords?
Epithelial, myoepithelial carcinoma in the lungs, because there are many cases where this neoplasm is localized, for example, in nasal cavity or in larynx. So there are numerous articles on this topic, but on pulmonary localizations, there are few articles.
Just, expand your search to Scopus Web of Science. And I think that's a nice case presentation. I think for the Polish Journal of Pathology would be quite okay. Thank you. Thank you.
Thank you very much. And this was the last presentation for today. We'll do a 15-minute break, and after that, the jury will announce. I will ask you to wait outside, and we'll call you. Thank you.
Absolutnie, to takie mam wrażenie.
intensywnej terapii.
Dokładnie. Tak, myśleliśmy.